Good morning all. I am Dr. PJ Madam Rafi. Today we are going to discuss about important topic diarrhea, types of diarrhea and its management. Okay. So first we'll discuss diarrhea. 3 or more watery stools in 24 hours period is diagnosed as a diarrhea. Diarrhea occurs due to passage of excess water in the fecus. It may be due to inflammation of gut mucosa. Okay. What are the reasons or what are the etiology for inflammation of gut mucosa? Whether it may be due to toxins, that are bacterial toxins. What are the examples? Cholera toxin or exotoxin or enterotoxin, Staph aureus induced toxin, salmonella or prostaglandins. These toxins will rise cyclic AMP or cyclic GMP in the intestinal villi. This increasing of cyclic AMP and cyclic GMP, it will lead to efflux of sodium and chloride into the lumen. Thereby, more water will be flushing out of the in the lumen. Thereby, leads to cause diarrhea. Okay. Next is in diarrhea there will be two transporters will be involved. So in those two transporter, one transporter will be affected. What is that is sodium chloride transporter. Intact transporter will be sodium glucose transporter. These two are important MCQs you have to remember. Affected transporter will be sodium chloride. Intact means non-affected, that is sodium glucose. Okay. Next coming to the types of diarrhea. There are two types: non-invasive diarrhea, invasive diarrhea. Non-invasive diarrhea means there will be no invasion of bacteria into the intestinal part. So symptoms like watery diarrhea without blood or mucus. Okay, and frequent vomitings will be there. Periumbilical cramps will be there. If fever will there will be chancing of fever will be less. Okay, if it comes also it will be very mild. Okay, but the sources of invasive diarrhea will be cholera, enterotoxin, salmonella, staph aureus, bacillus. Okay, these sources will cause rise of cyclic AMP, therefore it will induce diarrhea. Okay, next will be invasive diarrhea. Okay, invasive diarrhea symptoms will be slightly loose smaller volume of stools with mucus or blood. Okay, that means this is the fundamental difference. In invasive will have mucus or blood, but in non-invasive doesn't have mucus or blood in the stools. Abdominal cramps, urgency, mild dehydration. Here we don't have any vomitings, no vomiting will be there, but fever will be compulsory. Invasive area fever will be there, non-invasive area mostly fever will not be there. If comes also it will be very mild. Sources will be Shigella, E. coli, Clostridium jejuni, Staph aureus, type Salmonella typhi, Histolytica, Clostridium difficile. Okay, these are the sources for invasive diarrhea. Okay, next principles of management. Treatment of fluid depletion. Obviously, because there will be more loss of fluid, so we have to be correct those fluid. So once fluid will get corrected, shock will be get corrected. If chance patient will have acidosis or metabolic acidosis, we have to give soda bicarb to compensate acidosis. Next, maintenance of nutrition, because more fluid, more glucose will be lost out. So we have to more electrolytes also more electrolytes also lost. Okay, so we have to correct this thing also, maintenance of nutrition. Next, drug therapy. Okay, what are the drug therapy we will see in following slide. First we will see mostly antibiotics will use in drug therapy. So salmonella infection will have ciprofloxacin or IV ceftriaxone. For travelers diarrhea will have ciprofloxacin, norfloxacin, doxycycline or chlorotrimazole. In invasive diarrhea we will use ciproflox or norflox or aflox or chlorotrimazole. Next, for cholera, tetracyclines or chlorotrimazole. For Campylobacter jejuni, we will use norfloxacin. For Clostridium difficile, so this is the MCQ. Clostridium difficile will cause pseudomembranous enterocolitis. Okay. For this, drug of choice will be metronidazole. If metronidazole resistance, we will go with vancomycin. Okay. Next, amoebiasis and giardiasis will use drugs like metronidazole and diloxanate furoate. Okay. So these are the some antibiotics we'll use in bacteria-induced diarrhea. Okay. Next is probiotics. So probiotics mostly will use in acute diarrhea. Okay. They will restore and maintain the healthy gut flora. Okay. What are those? Econom sachets, Enterogermina respils, Porlac D. These are our intestinal bacteria we are giving as supplements. What are those examples like Saccharomyces, Lactobacillus, Bifidobacterium, Bacillus classy. These are intestinal bacteria and healthy bacteria. They are useful for food absorption. Okay, to maintain the healthy gut flora. So we will give as a supplements in acute diarrhea. Okay. Next, anti-secretory drugs. Okay. So anti-secretory means we have to decrease the intestinal secretion by using drugs like resicadrotry. Okay, it is a prodrug. It is converted to thiophane, which inhibits N-caffeinase inhibitor. Okay, by prevent degradation of ENK, that means N-caffeinase, which are mainly opioid, delta opioid receptor agonist. So obviously opioid receptor agonists, so they will decrease intestinal hypersecretion without affecting motility. Okay, we are not these are, that's why it is an anti-secretory, not anti-motility. So they will cause and they will affect only the secretion. They won't have any effect on motility. Okay, that is resicadrotry. Next drug will be bismuth subsalicylate. Okay, in bismuth subsalicylate, it will reduce prostaglandin synthesis and chloride secretion. There how it will show anti-secretory activity. Next, anticholinergic drugs, and obviously anticholinergic drugs will decrease acetylcholine level in the gut motility. So obviously when acetylcholine will be reduced, there will be no releasing of some more fluids into the stomach. Okay, that means intestine part. So obviously it will have anti-secretory property. Next, octreotide, it will have anti-secretory. Next, opiates. Okay, this is also showing anti-secretory drug property. Next group will be anti-motility drugs. Okay, anti-secretory means they will decrease secretion, fluid secretion into the lumen. Okay, so thereby obviously once you decrease the secretion, there will be no much fluid come to the lumen, so there will be no losing of more water. Okay, next group will be anti-motility. We have to reduce the motility also by increasing tone and segmenting activity of bowel. So reduce propulsive movement and diminish intestinal secretion while enhancing absorption. Okay, these antimotility drugs, what will they do? They increase the tone and segmenting activity of bowel. Thereby, intestinal movements will get suppressed. Okay, major action is mediated to the mu opioid receptor. Okay, so drugs like obviously mu opioid receptor agonists like codeine. Okay, but we will not use mu opioid receptors because of the developing chance of dependence. So we are not using now. Okay. Next group will be diphenoxylate. Okay, diphenoxylate is a synthetic opioid used as a constipating agent. It will be, yeah, we will add atropine for this diphenoxylate because of developing dependence. So to avoid the dependence, we'll add atropine. Okay, if you see codeine will have a chance of developing of dependence. So this drug diphenoxylate is synthetic drug. That's why we are adding atropine for to diphenoxylate to avoid dependence. Okay. It will cross blood-brain barrier, but it is contraindicated in children due to chance of developing toxic megacolon. Okay. Next drug will be loperamide. It is the most common used drug. Diarrhea means we will prescribe loperamide. Okay. So most common used drug in adults. It is more potent, major peripheral mu opioid agonist, and has weak anticholinergic property. Okay. It will inhibit secretions also. Okay, longer T-half, that means 12 hours. But these anti-motility drugs will not be useful in all conditions. Okay, there will be some caution. What is means anti-motility drugs are contraindicated in acute diarrhea due to invasive organisms. Whether there may be invasive means that means it is diarrhea is causing due to bacteria. Okay, so when in those conditions means bacteria will be present in the intestine. In those patients, if you prescribe anti-motility, obviously there will be decreased motility. So leads to accumulation of more bacteria and development of more bacteria in the lumen causes increased systemic invasion. That means sepsis. Okay, that's why if it is non-invasive or invasive, we have to find out. If it is invasive bacteria induced diarrhea, we have to avoid anti-motility drugs. Okay, so that will be very cautious thing. We have to be remembered. That's all. Thank you.